Hello, everyone. We are Team 4, and we'll be talking about the healthcare system in Canada. My name is Rohan Bhojwani, and my other team members are Sri Durbhakula, Zoila Gonzalez, Rosemary Hirata, Eric Jones, Cynthia Liu, and Daria Terrell. This is the agenda for the following presentation. So let's dive right into it. So, the healthcare model in Canada is commonly referred to as the National Health Insurance System. Although it is also known as Medicare, the model originated in Canada and is unique to the country. So, the Canadian NHI model is a publicly funded, publicly administered system that provides universal healthcare coverage to all citizens and permanent residents. It is funded through taxes and provides coverage for medically necessary hospital and physician services. Under this, there is no requirement for patients to pay out of pocket for basic healthcare services. It is based on the principles of equal access and equitable distribution of healthcare resources. But it wasn't all hunky dory. In 1962, there was a strike which took place in the province of Saskatchewan, lasted for 23 days, and involved doctors protesting against the introduction of a government funded universal healthcare system. Prior to the strike, healthcare in Saskatchewan was largely delivered by fee for service doctors who charged patients directly for their services. This meant that many people, particularly those on low incomes, were unable to access healthcare. The government, then led by Premier Tommy Douglas, sought to address this by introducing public healthcare system that would be funded by taxes and available to all residents of the province. However, many doctors opposed this idea, arguing that it would lead to a lower quality of care and reduced incomes for physicians. In response to the government's plans, the Saskatchewan College of Physicians and Surgeons, which represented the province's doctors, called for a strike in July 1962. During this, most doctors closed their practices, leaving many patients without access to health care. The government then responded by bringing doctors from other provinces and countries to provide care and also setting up temporary clinics staffed by nurses and other healthcare professionals. After 23 days, the strike was called off, with the government and doctors reaching a compromise that allowed for the introduction of universal healthcare while also addressing some of the doctors' concerns and compensation. The introduction of universal healthcare in Saskatchewan was a groundbreaking moment in Canadian healthcare history, and it paved the way for similar systems to be adopted in other provinces and eventually at the national level. Today, Canada has a publicly funded healthcare system that provides basic medical services to all citizens and permanent residents. Overall, this system has been successful in providing universal healthcare coverage, although it continues to face challenges related to wait times, access to healthcare, particularly in remote areas, and rising healthcare costs.
Next, we will be providing information about Canada as a country. The word Canada is derived from the indigenous word Kannada, meaning a village or settlement. Canada is the second largest geographical area in the world after Russia, but is one of the most sparsely populated countries. Most of the population is actually along the southern border, thus, those farther out north make up the more underserved population. Canada has a high Human Development Index, or HDI, of 0.936. It is considered a highly developed economy by UN definition. For comparison, the United States HDI is 0.91. Most developed countries have an HDI score of 0.8 or above. One interesting aspect of Canada is its decentralized, universal, publicly funded health system called Canadian Medicare. Medicare is healthcare that's administered primarily by the country's 13 provinces and territories. Because it's administered separately, benefits and delivery approaches may vary. We will discuss more in detail about Canada's health system later in the presentation. According to the Canadian Census in 2021, there were 38 million people living in Canada. In comparison, the US population was 332 million at that time. Canada had a poverty rate of 8% in 2020, while the US had a rate of 11%. Gender-wise, Canada has a roughly equal 50-50% of male to female population. About 2/3 of the population is age 15 to 64, and the remaining 1/3 is split between age less than 65 and age greater 65. Based on the birth and death trends, the number of elderly citizens is growing faster than the adolescent population. These two bar graphs show the comparison of the US to Canada in terms of population and GDP. This slide and the next slide use the year 2019 for comparison to look at health expenditures prior to the pandemic. The graph on the left shows the US having a population that's almost 9 times greater than Canada. This is similar to the numbers that we see today. On the right, the US is demonstrated to have a GDP that's 12 times higher than Canada. The bar graphs here compare the health expenditures as percentages of GDP and dollar amounts per capita. This is in respect to the GDP and population of 2019. In both charts, the expenditure is much higher for the US compared to Canada. This could indicate that Canada is more cost-effective at utilizing its healthcare resources in comparison to the US. This slide shows the political indicators of the two countries. Overall, Canada appears to be rated higher than the US in terms of political stability. Now we will discuss Canada using the PES analysis. P stands for political. Canada is a powerful country and was a founding member of the United Nations. Crime is very low, and the police are generally much more respected than any other country. As mentioned in the previous slide, the political stability of Canada seems to be better compared to the US. The E stands for economic. Canada has one of the largest economies in the world and is currently ranked number 9. International trade, including both exports and imports, is a large component of Canada's economy. These each make up about 1/3 of its GDP. Canada also has high levels of tourism, which is one of the very few sectors that is present in every local economy. Before COVID-19, the tourism sector employed 1 out of 11 Canadians and contributed $105 billion to the economy. The S stands for sociological. Canada is known for its ethnocultural and religious diversity. However, due to the decreasing rate of births compared to the stable rate of deaths, there are labor shortages across all sectors. To aid in recruiting foreign workers, Canada has implemented a flexible immigration system. In terms of health, Canada has multiple socioeconomic disparities that present many healthcare challenges even today. The T stands for technological. In 2019, 86% of Canadian family physicians reported using EMRs in their practice. This figure, while still below the national average of 93%, has more than doubled in the past decade for Canada. The government is also providing support and funding through various programs, including the Digital Literacy Exchange Program. The DLEP, which was launched in 2018, will invest $17.6 million to support local initiatives at teaching digital literacy skills. Socioeconomic inequalities represent a major challenge facing the health system. Cancer, mainly lung cancer, and heart disease have alternated as the main cause of death in Canada. Improved survival from these diseases are key drivers of recent increases in life expectancy. The third cause of death is COVID-19, and interestingly, the fourth cause is unintentional deaths. These accidental deaths include falls, poisoning, car accidents, drowning, suffocation, and fire. Lastly, other major public health issues are on the rise. These include increasing rates of opioid addiction and deaths.
Thank you, Cynthia. My name is Eric, and I will now begin the discussion on the health system structure within Canada. The key entities present in Canada's healthcare system are the federal government, the provincial and territorial governments, the ministers of health, insurance plans, the healthcare workforce, and ombudspersons. The government has a major role within healthcare of Canada. Canada's provincial and territorial government's role is to finance, organize, deliver services, and supervise providers within the federal health system. The federal government delivers funds to assist the 13 provinces and territories on a per capita basis and delivers healthcare services to select groups such as Indigenous people, armed forces, veterans, select refugees, and inmates. It also regulates the safety and efficiency of products such as medical devices, pharmaceuticals, natural healthcare products, and it funds research, some IT systems, and administers public health function on a national scale. The ministers of health are responsible for maintaining and improving the overall health care of Canadians by enacting policies and providing guidance. They are supported by the Health Portfolio, which is a group of various agencies and organizations. Each of the 13 provinces and territories all have their own individual insurance plans that cover necessary medical hospital and doctor services. The healthcare workforce is responsible for delivering healthcare services to those in need. With the Medicare model and healthcare insurance for all, Canada has a social justice orientation. Certain issues present currently are consideration to whether the healthcare for all model is sustainable due to rising costs. Since Medicare is funded primarily through taxation, managing costs would need to be passed on to workers. Even with the goal of providing healthcare services to all Canadians, inequality still exists within the system. This proves especially true for the Indigenous population and lower income people. The recent pandemic further exposed this as higher mortality rates existed among these populations. The prevalence of tuberculosis, obesity, and various chronic diseases were all higher within Indigenous people. Improving the efficiency of the Medicare coverage to include needed services or products was also an issue. This included non-emergent dental care, residential care, and pharmaceutical costs. These currently must be paid for out of pocket or through private insurance. In recent years, considerable wait times for services have offered concerns for whether citizens were receiving timely care. This has brought some to question whether privatization of care may play a bigger role in improving healthcare. Now on to Daria.
The national health coverage is achieved by 13 provincial and territorial health plans. There are special provisions for coverage that are defined by regions for special populations such as the elderly, youth, those receiving social assistance, and for immigrants and refugees through the interim federal health program. The health insurance plans share common features and provide basic standards of coverage for services that maintain health, prevent disease, which is a major priority for the country, and diagnose or treat an injury, illness, or disability. While the Canada Health Act mandates basic health care coverage for all, it does not define what is medically necessary and leaves that for the provinces and territories to determine. So what services are covered by national health insurance? Physician visits, including preventative care such as immunizations, hospitalizations, dental care if done in a hospital, prescriptions for inpatient hospital care, and laboratory and other diagnostic services needed to diagnose conditions requiring hospitalization. Hospitalizations, physician services, and prescriptions are the top expenditures among services provided by national health insurance. While Medicare provides basic coverage, not all services are covered. Therefore, 2/3 of Canadians also have private insurance for those uncovered services. Employers pay for this in about 90% of cases. Unlike in the beverage model we studied last week, private insurance does not share the same coexisting status in Canada. It is actually illegal for patients and insurers to pay privately for services covered by Medicare, and this helps to reduce inequities in access. A small percentage of Canadians pay for uncovered services out of pocket or are uninsured. 72% of healthcare expenditures come from public funds, while the other 28% come from private funding, which can be from out-of-pocket spending, private insurance, accident, or disability insurance. One of the focal points of the topic of coverage is outpatient prescription drugs. While not covered by Medicare, there is some coverage in some provinces and territories for youth and the elderly and those with low income. Quebec mandates that its citizens have separate prescription insurance. Most other expenses are covered by private plans or out of pocket, but drug prices are much lower in Canada. Optometry coverage includes an annual eye exam in most areas for special populations, with additional coverage only in a few areas. Portability of care allows coverage within Canada, and emergency care is provided through most provinces and territory plans while out of the country, but it is covered at the rate of the home province, which is often very low compared to fees in other countries, so additional travel insurance is usually recommended. Mental health and addiction care are provided, and the government will cover all or part of a treatment in publicly funded centers, but wait times are very long, causing some to seek treatment in private centers. Palliative care is another area of interest because it is provided in a hospital, but not if done in a long-term care facility. Similarly, the cost of home hospice equipment is also not covered, which leads us to one of the major questions. What is not covered under national insurance? Preferred hospital accommodations such as a private room, a telephone, or a TV in your room are not covered. Private duty nursing, long-term care, ambulance coverage, even though it is associated with emergency care, which is covered, air travel, even if recommended, and other services such as circumcision and orthodontics and dental care, which is not administered in a hospital. Even completion of forms for employers and schools are not covered and also carry fees. These services are not covered conceivably to reduce costs, which is the topic that Rose will discuss next.
Hello, my name is Rosemarie Harada, and I will be covering Canada's health system performance in the areas of cost and quality. The line graph on the left represents healthcare expenditures over the last 40 years. The orange line represents 1997 constant dollars, and the bluish-greenish line represents current dollars. Based on this graph, produced by the Canadian Institute for Health Information, the total health spending in Canada was forecasted to be approximately $331 billion in 2022. In other words, healthcare spending per person or per capita was forecasted to average about $8,563. In 2022, health expenditures were forecasted to be approximately 12% of Canada's gross domestic product, following a high of 13.8% in 2020. The graph to the right shows how Canada's healthcare spending compares to other countries. According to the Organization for Economic Co-operation and Development, or OECD, Canada's per capita spending on healthcare was among the highest internationally in 2020, but still less than the United States, who remained at the highest at approximately $15,275 in 2020. Healthcare spending growth spiked at 13.2% in 2020. This was due to additional funding to scale up health system capacity, testing, and vaccinations in response to the global pandemic. At the same time, the economy was negatively affected by restrictions put in place to contain the spread of the virus, such as lockdowns, closure of some businesses, and travel restrictions, which resulted in a 4.5% drop in the gross domestic product growth rate. The growth rate for healthcare spending is expected to decrease as Canada's economy is expected to grow. So where is most of the money being spent? In 2022, it was forecasted that hospitals, physicians, and drugs make up the largest share of healthcare dollars at 51.5% collectively, over half of the total healthcare spending. The other shares include expenditures on public health, home and community care, and other professional and institutional care. The growth rate of healthcare expenditures by category may warrant further analysis to identify any areas or opportunities for improvement. Because as you will see on this slide, Canada ranks number 1 for healthcare expenditures as a percentage of GDP out of 30 countries with universal healthcare systems, according to the Organization for Economic Cooperation and Development. This means Canada ranks as the most expensive universal healthcare system among these 30 countries, yet its performance for use of resources and quality and clinical performance is modest to poor. There appears to be an imbalance between the value Canadians receive and the relatively high spending on their healthcare system. Another area that is worth diving deeper into is how their per capita costs compare by province and territories. As you see on the illustration on the right, there are 3 provinces that have a significantly higher healthcare costs per capita than the average, 2 of which show approximately $22,000 are forecasted to be spent on healthcare per person in 2022. In terms of key performance measures and quality, Canada ranks 16th in life expectancy at birth, 13th in healthy life expectancy, and 14th in the treatable mortality rate when compared to 30 other countries with universal healthcare systems. What is most concerning is the low ranking in infant mortality rates and perinatal mortality rates. Canada is ranked close to the bottom at 28th in infant mortality rate and out of 30 countries, and 20th for the perinatal mortality rate. Canada recognizes the need to improve their healthcare system, and on February 7th, 2023, the Government of Canada announced that they would work collaboratively with the provinces and territories on 4 shared health priorities, which are expanding access to family health services in rural and remote areas, supporting health workers and reducing backlogs, improving access to quality mental health and substance abuse services, and modernizing the healthcare system with standardized health data and digital tools. Canada plans to invest $196.1 billion over 10 years, including $46.2 billion in new funding for provinces and territories to improve healthcare services for Canadians. The Canadian federal government plans to measure and report annual progress using the common indicators that are listed on this slide, because what gets measured gets done. For example, it was previously shown that when looking at doctors per 1,000 people, Canada ranked 28th out of 30 countries with a universal healthcare system. This means Canada has significantly fewer physicians per capita compared to the average of the 30 countries included in the comparison. To address this issue as part of Canada's new improvement effort, the federal government will monitor and measure the number of new family physicians, nurses, and nurse practitioners, along with access to the family health team. They also plan on measuring wait times for community mental health and substance use services and the percentage of Canadians with a mental disorder who have unmet mental health care needs, just to highlight a few of the key measures on the slide. Now we'll turn it over to Sri, who will go over Canada's health system performance in access and equity. Thank you.
The founding principle of Canadian healthcare was in fact that access was based on need rather than ability to pay. The criteria for federal contributions under the Canada Health Transfer include public administration being nonprofit, comprehensiveness including all services rendered throughout healthcare system, universality including all residents, portability including access in all locations, and accessibility for all groups of people. Despite its initial noble intentions, unfortunately, Canada ranks the worst among the 11 OECD comparators in several areas in recent review, including France, the UK, and the United States. In fact, it ranks the worst as far as average length of hospital stay days of 7.5 days. 63% of Canadian citizens note difficulty with after-hours care. 30% report waiting greater than 2 months for a specialist. 18% report waiting greater than 4 months for elective surgery, and 17% report ER visits due to lack of access. These are all the highest rated among the 11 OECD countries. So in fact, the system has become a bit antiquated and has not really responded to the changes in the demographic population of Canada. There are several barriers to improvement in access. Foremost is the lack of physician and provider incentive to work harder and accountability and allow more access for patient care. There are very poor relationships between federal, provincial, and territorial governments, resulting in poor collaboration. And the real issue is that there's actually quite reasonable performance on composite quality metrics. Therefore, wait times for elective care, in essence, don't really translate into worse healthcare outcomes. So therefore, there's less impetus to change the status quo. In fact, several provincial laws actually prevent the expansion of privately financed care to offset some of these changes that are occurring. And we'll cover that briefly with prescriptions as well. In response to demographics, 1 in 5 Canadians are actually foreign born. This results in a high number of vulnerable groups, including refugees, migrants, and immigrants. Geographic complexities amongst this massive country are also challenging. 18% of Canadians live in remote communities, and 58% live in Indigenous territories, have no local access to healthcare. Interestingly, 1/3 of working Canadians lack supplemental private insurance coverage, and this specifically involves women, youths, and low-income individuals who are vulnerable but not allowable to government funding. Public coverage generally focuses on seniors and the unemployed, and such inequities and outcomes are driven by social determinants of health. Interestingly, Canada is the only developed country with universal health care coverage that does not include prescription medications. As such, 57% of prescription spending is financed through private means, and 1 in 4 households report not taking medicines due to the inability to pay and lack of private health insurance supplemental coverage. Several barriers to improvement in equity have been noted, including inequitable access to home-based care and institutional long-term care. In fact, several Canadians who need help at home did not receive it. Several issues also include inability to pay and lack of public financing for those in need. Unfortunately, Indigenous populations are marginalized. In fact, in a recent evaluation of First Nations, Inuit, and Métis, which represent 3% of the population, there are clearly higher rates of chronic disease, trauma, violent suicide. There's decreased life expectancy, and in fact, 3 times higher infant mortality rates compared to the Canadian average. And the wage gaps are significant, with greater than 50%. Also, there's significant racism and social exclusion. So the barriers for these folks are quite high to get proper access to healthcare. And indeed, there is inequity in the system. There are clear opportunities for improvement in the Canadian healthcare system. Provincial and territorial governments need to work together and collaborate, reorganizing resources and building infrastructure amongst provinces. There needs to be a concerted effort to improve wait times and improve access and equity for all of the population of Canada. The scope of public basket of services needs to be expanded, specifically as it relates to universal prescription drug coverage and expanded home care and long-term care and mental health services. Other opportunities for improvement include the Healthcare Innovation Fund to accelerate and scale up promising innovations. Also, the focus needs to be changed from the composite quality metrics, which are somewhat biased, to reflect the real issues with access and equity in the entire population. And it'll also look at other metrics that are equally important for patient satisfaction, including wait times. Telemedicine services have shown significant improvement, as they've improved from 23% to 73%, but still much work is needed to include telemedicine services to folks that cannot have direct access to healthcare. We need to think about increased regional and mobile healthcare delivery models to remote areas. And then we need to align provider incentives with improved access. So essentially, we need to make it more profitable and more desirable for physicians, nurses, and other healthcare providers to want to expand the scope of their services offered. There needs to be a focused commitment to underrepresented minorities, and we need to expand access to private health insurance models which can offset some of the prescription drug costs that are not covered under the current model.
Thank you. My name is Zoila Gonzalez, and now we will discuss the areas of excellence and major innovations. Canada has a decentralized, universal, publicly funded healthcare system. The main areas of excellence are the following. It's universal. All provinces and territories offer universal health services provided by hospitals or physicians. All coverage is portable across provinces and territories. They offer comprehensive health services, and these services are provided without charge at the point of service. And the result is a narrow but deep public insurance structure. There is a long list of Canadian medical innovations. One of the most useful today is a life-saving treatment for diabetes. Before this discovery, diabetes was a death sentence. Half of the people who develop it die within 2 years. Thanks of insulin therapy, many people now live into their 50s and beyond. Also, they discovered the first Ebola vaccine. However, in terms of innovation, international comparisons suggest that Canada ranks low among countries that offer universal health coverage. That's why the government launched the Advisory Panel on Healthcare Innovation, which aims to identify the 5 most promising areas of innovation that have the potential to reduce health spending while leading to improvements in the quality of care. And the 5 areas are patient engagement and empowerment, health system integration with workforce modernization, technological transformation via digital health and precision medicine. Precision medicine aims to improve disease prevention, diagnosis, and treatment. Better value from procurement, reimbursement, and regulation. And finally, the health industry as an economy driver and innovation catalyst. This area aims to accelerate the adoption of disruptive technologies that show value for money and benefits for patients. There were several reforms in the Canada health system. The main happened in 2004 when the government agreed on a 10-year plan to improve Canada's healthcare. The areas of focus were waiting times, home care, national pharmaceuticals strategy, prevention, and the public health promotion. As we mentioned before, prescription drugs outside hospitals are not universally covered, but there are efforts to implement a drug coverage system. In 2018, PharmaCare was established. In Canada, universal public health insurance ends as soon as a patient receives a prescription to fill. One of the significant government reforms is the implementation of PharmaCare. In June 2019, the Advisory Council passed federal legislation for the universal coverage of essential medicine in 2022. It will be then expanded to become a comprehensive system of public drugs coverage by 2027. If this national program moves forward, it will be the biggest public funding and coverage expansion since Canadian Medicare was introduced. Now it's time for the improvement opportunities. Thanks.
To summarize improvement opportunities, we need to continue to integrated healthcare for Canadians by expanding access to family health services, including rural and remote areas, by supporting our healthcare workers and reducing backlogs, by improving access to quality mental health and substance abuse services, and by modernizing the healthcare system to include expanded EHR, telemedicine, and standardized data and digital tools to drive outcome measures. In addition, we need to think about expanding the scope of services covered, including prescriptions, long-term care, and mental health. We need to once again incentivize providers and align interests to expand and enhance service lines. We need to reorganize territorial and provincial infrastructure and funding. We need to shift the focus from composite quality metrics to wait times and patient satisfaction and other modernly used metrics. We need to expand telemedicine services and improve mobile health delivery models. And finally, we need to dedicate resources to better serve underrepresented minorities.